I'm Dr. Imran here. We are going to continue with the female genital system and pathology of breast from today onwards. Uh, Initially, in the last two lectures, we discussed the common sign and symptoms of diseases related to breast, common investigations which can be done in case of a breast disease, and what is self-breast examination. I'm not going to go into the details of many things which are written in the book. I'm going to emphasize more on the practical aspects, but you have to read the chapter as a whole once. So let's start with the diseases of the breast. In any organ or tissue of the body, the diseases can be classified as congenital or hereditary diseases, inflammatory diseases, then autoimmune diseases, and uh, diseases which are related to other etiologies. And in the last, there are tumors related to every tissue in the body. So we are going to go in this sequence, and let's start with uh, the inflammatory diseases of the breast. We already discussed the congenital malformations of nipple in the last lecture, and we dealt with the male breast diseases, which are commonly gynecomastia, and the tumors in male breast are only 1%. So now the breast diseases we are dealing are in the female breast tissue. So, to start with, mastitis is the inflammation of the breast, and that may present as signs of inflammation anywhere in the body. So, there may be pain, swelling, redness. The patient may have a fever. There may be a discharge that may be a pussy discharge, or maybe a fluid or a blood stain discharge, depending upon the type of the area involved and type of the infections involved. Most of the infections in cases of breast tissue occurs in lactating females, and may be part of the trauma, but uh, most of the time the mastitis is acute mastitis. Chronic mastitis is something uncommon or rare in breast. Granulomatous diseases in case of breast are again very rare. Most of the time it is tuberculosis secondary to the pulmonary tuberculosis, but again there are only case reports in the world in which breast is involved by tuberculosis. It is not very common thing, but can be involved by tuberculosis in case of chronic diseases. But most of the time the mastitis is acute mastitis, and it is bacterial mastitis. So that is why discharge or a pus-like discharge is one of the common features. The breast may show tenderness on palpation. This is a picture showing the clinical presentation of mastitis. The skin is red and tender if you palpate. The nipple may be having discharge. If you take a history, it will be a short history, but first we have to rule out any pathology in the breast, and then we also have to rule out any pathology in the skin itself. It may be a dermatological disease presenting as the sign and symptoms of um, this mastitis. But first, you have to rule out mastitis itself. Again, you may have a lump or a redness. This is again massive mastitis. In cases of mastitis, first you have to treat the patient with antibiotics, and you have to subside the infection. If there is any pus pockets or there is formation of an acute abscess, then you have to drain the abscess by incision and drainage, and then give IV antibiotic because sometimes it is difficult for the infection to subside, and it is collected as a pus and an abscess is formed. See this, there is blackening of the skin. The skin is also involved, and that shows gangrene in some parts. Redness is there. So, in case of mastitis, if you see a slide, it is nothing but what you have already done in third year. That you can see this is the breast tissue, this is stroma, these are the ducts, and you have a lot and lot of inflammatory cells around the duct and the lobules. The cells are going to indicate whether the infection is acute or chronic. So neutrophils are present in acute, and if the infection is chronic, you are going to see lymphocytes and macrophages. So again, showing you that this is a distorted duct with inflammatory cells all around, and also you have macrophages inside the duct instead of the secretions. You may have inverted nipple in cases of a chronic infection because of fibrosis, because as already done in third year, whenever there is fibrosis, there is going to be contraction of the fibers, and there is going to be retraction of the nipple. That retraction of the nipple may indicate that there is a tumor underneath, but from history and examination and from signs of inflammation and a short history, it may be an infection or mastitis that may have reverted the nipple. This is a slide you have already seen in third year. Again, emphasizing this here with the breast diseases. This is fat necrosis. In breast, fat necrosis occurs because of trauma, because of an accident, because of a fall, and a very common scenario is that the trauma can be because of the head of the baby that is lactating. So the mothers who are lactating may have a trauma from the head of the baby that may cause fat necrosis. Fat necrosis can present as a lump in the breast. So you may have a history of trauma with the baby's head, and after a week or so, the patient may present with a lump. There is no pain in the lump, but initially, when there was a trauma, the patient might have pain that may subside with analgesics, but after a week, when there is a lump in the form of fat necrosis, the patient may not have any pain. The treatment is that you have to remove that area of fat necrosis which is presenting as a lump. Here we have a fat, and you have a lot and lot of macrophages, which is one of the indication that the fat is undergoing necrosis. This is a giant cell, multinucleated giant cell engulfing the degenerated fat. Periductal mastitis is another um, entity, and this periductal mastitis is an entity on the microscope. So if you have inflammation just around the ducts and not in the stroma, it is called periductal mastitis. Sometimes large ducts are involved, like lactiferous ducts are involved, and that may present as swelling and redness just in the areolar region. That is one of the indications clinically that it is a periductal mastitis. So this is periductal mastitis. You have these distorted ducts, you have macrophages in the lumen, and you have a lot of cells, inflammatory cells around the ducts. This picture shows a nipple and areola showing pus oozing out. So if there is discharge on pressing the nipple and areola, it is an indication that first you have to rule out mastitis or any fibrocystic disease rather than a tumor. So see this is a diagrammatic representation of um, a duct clogged with the secretions, inflammatory exudate, and the macrophages in cases of mastitis. Same can happen whenever there is blockade of the duct and the mother or the female is lactating. That may present as a galactocele. If there is a clogged duct, the lobule may enlarge and may dilate because of the presence of milk. If you do an FNAC, you are going to aspirate white fluid, that is actually the milk. In this case, again, you have to remove that lobule surgically. So see this, you have an enlarged duct with a lot of macrophages containing white vacuoles. This is actually the retained milk. And outside the duct, you have a lot of inflammation, and you also have some giant cells there. This is just in reaction to the inflammation. See this again. This is a large duct with secretion, that is the milk, and you have macrophages containing the white granules. Another beautiful picture showing this dilated duct. This picture shows granulomas. As I told you in the start, that uh, granulomatous diseases in breast may occur secondary to tuberculosis elsewhere in the body, and breast may be involved secondarily. Granulomatous, chronic granulomatous inflammation, that is tuberculosis, secondary to pulmonary tuberculosis, may occur in the breast tissue. So again, you have to rule out tuberculosis. If there are granulomas in the breast, you have to first rule out tuberculosis elsewhere in the body, then you have to rule out tuberculosis in the breast. Fungal diseases, parasitic diseases, or any other bacterial diseases do not cause granulomatous inflammation in the breast. I'm not talking about other tissues in the body, but in the breast, the most common is if you have, you first have to rule out tuberculosis. If there is no tuberculosis and there are granulomas without caseation, then the entity is called chronic granulomatous mastitis. So it presents as a lump in the breast for a long time. If you do a biopsy, you see granulomas. It is called chronic granulomatous mastitis. This is an entity just for the breast. But first, in case of granulomas, if you have granulomas, you have to rule out tuberculosis first, then granulomas. So present with having a swelling in the breast that subsides or reduces in size with the cycle, and then again increase in size and get tender when there is menstruation. So you have to ask the patient in cases of chronic inflammatory lesions of the breast, that whether the swelling subsides during the cycle or it stays as such. That is one indication. If the swelling is subsiding, that is one indication that this may be a proliferative breast disease, because this disease is related to the surge of the estrogen and the imbalance of the hormones. So this disease is hormonal and hormone related. So sometimes the patient is going to say that the swelling totally subsides and then it reappears again with the cycles. So proliferative breast disease, which was previously called as fibrocystic disease. So fibrocystic disease is often bilateral, while the tumor or cancer may be unilateral. But one of the tumors, which is lobular carcinoma of breast, it is sometimes bilateral. Um, Fibrocystic disease or proliferative disease may have multiple nodules or maybe multicentric. But usually, in cases of cancer, it is a single nodule. The fibrocystic disease is related to the menstruation cycle, while breast cancer is not. There is cyclic pain and enlargement while it is not related to the cancer, and it may regress during pregnancy, the fibrocystic disease. But in case of cancer, it is not going to regress. In cases of proliferative breast disease or fibrocystic breast disease, the patient may present with a lump that may move on palpation or on examination, while in cases of an invasive or malignant breast cancer, the swelling or the irregular mass is not going to move freely on examination or palpation. It is if you want to palpate or examine or move the mass, the breast tissue is going to move with the mass. But in cases of benign diseases or in cases of fibrocystic or proliferative breast diseases, the mass is in the form of a nodule which is going to freely move on examination. Fibrocystic means that there is fibrosis, and cystic means that ducts are enlarged or cystically dilated. This was the previous name, but now the same disease is called proliferative breast disease because there are other entities also other than fibrosis and the dilatation of the ducts. Let's see what are those entities. So this is a big picture showing a lot and lot of different things happening in the breast. So this is a beautiful picture showing you a proliferative breast disease. You have ducts and you have stroma and you have fat. In cases of ducts, you can see some ducts are dilated. So this is that the ducts are dilated, and sometimes they are so large that we can call them cystically dilated ducts. This is one entity. Why I'm emphasizing on the entities? Because when you are going to read a report regarding proliferative breast disease, a pathologist is going to indicate all the entities seen on the slide, because some of the entities in proliferative breast disease may be pre-malignant. So not all proliferative breast diseases are going to convert into a malignant tumor, but sometimes some entities in the proliferative breast disease may be pre-malignant. I'm going to tell you all those in the next few slides. So this is one entity, dilated ducts or cystically dilated ducts. Then you have a lot of small ducts. The ducts proliferate and give branches, and this is called adenosis. So number of small ducts proliferating in the stroma is adenosis. Then you may have a double layering of the duct. You may see that a duct is lined by a cuboidal epithelium, normally a single layered, but you may have doubling or double layering or layered epithelium in the duct. So sometimes there is papillary projections inside the lumen. You may have secretions in the lumen. You may have hemorrhage in the lumen. You may have macrophages and inflammatory cells in the lumen. You may have inflammatory cells around the ducts, but these are less than the mastitis, and these are always chronic cells like lymphocytes and plasma cells. This is a gross appearance of fibrocystic or proliferative breast disease. If you see this, this is fat, and in this fat, or the stroma, actually, sorry, I think there was a connection issue. So there is fibrosis in the stroma, and then you have cyst. Blue dome cyst in case of breast is just that, a cyst containing hemorrhage, and it is converted into blue colored or brown colored fluid that is called a blue domed cyst. See this, you have a lot of fibrosis in the stroma. You have adenosis, that is development of small branches from the ducts, and there are a lot of small ducts. You have cysts, you may have double layering. Then you have apocrine change of the cuboidal cells. Apocrine change means that uh, apocrine cells are actually the cuboidal cells, but apocrine, this word apocrine, we are going to use only if the breast is a lactating breast. But in cases of proliferative breast disease or fibrocystic disease, you may have apocrine change. The cells are not going to secrete milk, but you may have cells like you can see in a lactating breast. So this is a beautiful apocrine change. The cells are columnar, and you may have secretions. Uh, See this secretions in the lumen. You may have papillary projections inside the lumen. So see this apocrine metaplasia or apocrine change. Then you may have adenosis and fibrosis, which are combining with each other. You have glands surrounded by a lot and lot of fibrosis. This entity is called sclerosing adenosis. Sclerosing, it is that in slide, if you see a lot and lot of fibrosis, the area is called sclerotic. So sclerosing fibrosis is that you have fibrosis around the proliferating branches of the glands, which we previously called adenosis. So the entire entity is going to be called sclerosing adenosis. So we have all these entities, and whenever we are going to report as a pathologist, we are going to write proliferative breast disease showing all these or any of these entities. All these entities which we have discussed till yet, they are benign, and they are not going to secrete milk. They are not going to secrete Can you hear me? Hello? Hello? So if you have hello?
हेलो अस्सलाम वालेकुम सर।
जी वालेकुम सलाम.
सर आपकी आवाज़ आ रही है, आप कंटिन्यू कर सकते हैं।
जी. So if you have proliferative breast disease with ATP, that is important for the surgeon, because if you just have a proliferative breast disease, the treatment is that you have to remove the lump. But if you have proliferative breast disease with ATP, you have to follow the patient, because that may present later on with any other lump in the breast. A radial scar in a proliferative breast disease is that you have a lot of fibrosis in the center surrounded by dilated duct. That is just a gross and a microscopic examination. And this is again a benign entity. Ductal hyperplasia, as I told you, that a duct is lined by a cuboidal epithelium, but if you have double layering, that is that the ductal epithelium is hyperplastic. Again, this is one of the entities in proliferative breast diseases, but ductal hyperplasia is a benign entity. If you have ductal hyperplasia with atypia, that is something to be worried about, and that is something to be followed. So this is a ductal hyperplasia. You have a lot of layers of the epithelium. This is calcification. This is dystrophic calcification. You may see calcification sometimes in proliferative breast disease, which can also be seen on the mammography. See this. This is hyperplasia. There is lot and lot of hyperplasia, a lot and lot of proliferation of the epithelium, which may also clog the duct, or which may clog the lumen. Now, going further from this hyperplasia, as I told you that if you have atypical ductal hyperplasia, that may lead to first carcinoma in situ in the duct, and then may proliferate to invasive ductal carcinoma. So in cases of proliferative breast disease, if you have atypia, that is premalignant and to be worried about. Normal cells, ductal hyperplasia, atypical ductal hyperplasia, which is seen on microscope only. You don't have any evidence clinically. You have ductal carcinoma in situ, and if there is breach in the membrane and you don't have myoepithelial cells around the duct in the slide, that means that this is ductal carcinoma in situ. If there is a breach in the basement membrane, the cells are going to invade into the surrounding stroma, and that becomes an invasive ductal carcinoma. So you have normal hyperplasia, atypical hyperplasia, ductal carcinoma in situ, and then invasive carcinoma. So this is the scenario how, or this is the model that how an invasive ductal carcinoma may occur in breast. Ductal carcinoma, invasive ductal carcinoma is one of the most common carcinomas. We are going to deal that in detail in the next lecture on malignant tumors. So this is the summary what we have done till now. We have proliferative breast disease. We have some benign diseases. Then regarding neoplasm, we have certain benign neoplasm in the breast, and then we have a malignant neoplasm in the breast, which is the breast carcinoma. Today we are going to deal with one of the most common benign tumors in the breast, that is fibroadenoma. So fibroadenoma is a benign tumor of breast. This is the most common tumor occurring mostly under the age of 30 years in young females, maybe unilateral or bilateral, maybe single or multiple. It is called a breast mouse because it is an encapsulated benign entity. And if you palpate the breast on examination or palpate the lump on examination, uh, the lump is going to slip between the fingers. That is why it is called a breast mouse. The only treatment is that you have to remove that lump with the capsule and you have to save the breast. Once removed, this fibroadenoma is not going to reoccur. So a fibroadenoma is a benign, most common benign tumor in the breast, and this is the tumor which occurs only in the breast. There is no entity like fibroadenoma elsewhere in the body. It is an encapsulated tumor in which you have proliferation both from the epithelial component and the connective tissue or the stromal component. See this, this is mammogram showing a lump which is seen as an opacity. This white patch is actually the calcification. Sometimes fibroadenoma can show calcification, and the calcification in fibroadenomas, they are called popcorn-like calcifications. So this is a gross appearance of fibroadenoma. It is an encapsulated tumor, and you have this central um, tumor. Again, the surgeon is going to just remove the encapsulated lesion. On microscopy, you have a neoplastic stroma. You have a lot of fibroblast and fibrosis in the stroma. You have so you have this capsule around the duct. Again, this is a slit like duct, and you have this stroma around. If you do an FNAC of fibroadenoma, you are going to get these epithelial cells which are regular in shape and they are benign. And then you are going to get these stromal fragments. So combining these two things, we are going to give a report of a benign breast disease consistent with a fibroadenoma, and the surgeon is only going to remove the lump. This is another entity which is less common than fibroadenoma. This is called tubular adenoma. Again, a benign tumor in breast in which the epithelial component, like the fibroadenoma, the epithelial component is proliferating more than the stromal component. You have a lot and lot of small ducts. This is different from adenosis because you have less ducts and you have other entities of proliferative breast disease. So this is tubular adenoma. This is again an encapsulated lump. This is a benign tumor. This entity is called PASH, that is pseudo angiomatous stromal hyperplasia, PASH, PASH, that is pseudo angiomatous stromal hyperplasia. Pseudo angiomatous means that it look like that these structures in the picture, they are vessels, but they are not actually vessels. They are fibroblasts which are producing these collagen fibers, and they are arranged in such a way that they have gaps in between them, and they mimic as vessels. So this is pseudo angiomatous stromal hyperplasia. This is an entity which can be seen separately as well as a lump, or this entity can be seen around the tumors also. So if you have this entity, you have to rule out that whether there is a tumor in the vicinity or not. Then you can give the diagnosis of just PASH in your report. So see this, this is another benign tumor which is called Phyllodes tumor. This is a stromal tumor. Epithelium is not neoplastic, only the stroma is neoplastic. Phyllodes tumor occur mostly occur after the age of 30, but can occur under the age of 30 also. This is a big tumor. It almost covers the entire breast if it is diagnosed late, or sometimes it may mimic a carcinoma. But on FNAC, you are going to get stromal fragments which are actually benign. So see this, this is a benign phyllodes tumor. In this case, the if the patient presents with this big tumor, the surgeon has to do mastectomy. But in cases of smaller phyllodes tumor, the tumor is only removed and the breast is saved. So again, it may have calcification on mammography. This is phyllodes tumor. Phyllodes is a Latin word for leaf. So this is a tumor in which on microscopy you can see leaf-like patterns. So this is a leaf-like pattern. This is a leaf-like pattern. So actually you have a lot of stroma, and the epithelium is actually stretched on that stroma. This stroma is proliferating. Stroma is neoplastic, but it is a benign tumor. So phyllodes tumor is a benign tumor. It is an encapsulated tumor. See this? This is phyllodes tumor, and you have these leaf-like structure. This epithelium is actually stretched. This is actually the ductal epithelium, which is stretched in this pattern, and the stroma is so much that it is stretching the ducts. There is another entity called malignant phyllodes that is less common than the benign phyllodes. Mostly the phyllodes tumor is a benign tumor, but if you want to call it a malignant phyllodes, you have to fulfill certain criteria. Number one, that the stromal proliferation is much more than the benign phyllodes. Number two, you have pleomorphism in the nuclei. You may have a variable size and shapes of nuclei of the stromal cells. You must have atypical or uh, atypical mitotic figures, or atypical mitosis in the cells, again the stromal cells. And then you may have areas of necrosis. So exuberant proliferation, pleomorphism, then atypical mitosis, and then areas of necrosis. You are going to call it a malignant phyllodes. Benign phyllodes cannot metastasize, but malignant phyllodes can metastasize to axillary lymph node. And in this case, the metastasizing component is going to be the stromal component of the tumor. So this is the stromal component. In cases of, of a malignant tumor, you have a lot of proliferation. See this, this area shows pleomorphism, different shapes and sizes of the nuclei, then you may have mitosis. You may have atypical mitosis. Pleomorphism, and then this and this you have atypical mitosis. This is atypical mitosis in a malignant phylloids. This is an these are the stromal cells. Um, this is another tumor which I want to emphasize just for the sake, because it may occur in cases of breast. It is one of the malignant tumors of connective tissue. This is angiosarcoma. Angiosarcoma is a malignant tumor of blood vessels. Why to emphasize this in breast? Because angiosarcoma can be seen in patients who had radiotherapy for breast cancer previously. The patient may present with angiosarcoma secondarily, or may also present primarily with angiosarcoma. So breast is one of the tissues where angiosarcoma is one of the most common tumors, one of the most common malignant tumors regarding connective tissue. Regarding connective tissue. So the most common tumor in breast, malignant tumor in breast, is its own primary invasive ductal carcinoma. Then there are many other epithelial and stromal tumors of breast itself. Then regarding other components of the breast in its connective tissue, here the most common is going to be an angiosarcoma. So you have angiosarcoma in breast that may occur after the radiation also. So you have malignant cells lining the vessels. This is that if you see this picture, you have a patient who had a mastectomy already. The patient had an axillary clearance on the same side. The patient presented with lymphedema, and then that arm presented with angiosarcoma. This is one of the common scenarios of having angiosarcoma after mastectomy. The patient may present with angiosarcoma at the site of mastectomy also, and if you have a lymphedema of the same arm on the side where you have done the axillary clearance, the patient may present with angiosarcoma, and less likely or rarely or uncommonly with lymphangiosarcoma. Mostly it is angiosarcoma or hemangiosarcoma. So these were some of the benign tumors of breast and some of the connective tissue tumors of the breast. In the next lecture, we are going to deal with, in the next two lectures, we are going to deal in detail with the malignant tumors of the breast itself, and we are going to actually deal with the word breast cancer, and what are the types, the classification, how to diagnose, and what are the treatments. So that was all for today. If you have any question, please write them to the CR, and the CR is going to email me. I'm going to answer those questions. Thank you so much.